Thanks, Greg. Hi, everyone. My name's Sara Hungerford. I'm a cardiologist, and I'm in the pretty lucky position of being a PhD candidate with Chris Hayward and David Muller. Just had a nice trip to Japan, so it's all going very well. You can see here on the left-hand side, they should be playing on loop, but I want to talk today about the Tendyne mitral valve prosthesis and then touch on a few other things that we're doing. When playing, you can see that the patient demonstrates severe mitral incompetence. And here, playing on loop on the right, you can see in the parasternal long axis, this is a transcatheter Tendyne mitral valve prosthesis for those who haven't seen it before. It's a nitinol frame delivered transcatheter through a surgical puncture through the apex and then tethers to the apical region of the heart. I'm going to talk to you about why I think this is useful. So in the next slide here, you can see just how effective this transcatheter solution is in reducing mitral incompetence. And that's what we saw in our cohort of patients. I have no disclosures. Why do we care about RV dysfunction in MR? Well, it's common. We often forget about it, but it has really important prognostic implications. When we look at surgical patients who have MR and go on to surgery, 30% of them have an ejection fraction less than 35%. More than half of them also have left ventricular dysfunction, but RV dysfunction can occur even when the LV is normal. And I guess pulmonary hypertension is also a really poor indicator of outcome after surgery in patients with MR. We also know in the surgical patients that the LV and RV will improve after surgery. So what do we know about transcatheter interventions and what they do to the right ventricle? Very little, and that's why we're looking at that at our centre. Why does it happen? I think the fourth point on my slide is the immediate thought first. Everyone attributes raised pulmonary artery pressures from left atrial dilatation, right ventricular afterload, leading to progressive heart failure and pulmonary hypertension. But if I want you to take one thing away from today's talk, it's don't forget the left ventricle's role in the right ventricular function. The left and right ventricular remodelling, the septal function of the LV, the myocardial function of the LV, and the constraints of the two. So the left ventricular function and size is so important. We know that right ventricular function overall may be preserved despite the free wall being abnormal if the septum is moving quite vigorously. But we know that in chronic MR with the volume-loaded ventricle, the septum is often one of the first regions to go. And the other thing is, as the ventricle dilates and the pericardial constraints are placed on both the right and left heart chambers, we also see that the RV tends to decline. So what have we done at St Vincent's? Well, this is just one of my many PhD projects, but I've looked using right heart catheter and echo at the right ventricular remodelling, and we looked at day 1 and then at 1 to 3 months. So we've had only 12 patients go through our centre. I know Prince Charles has had a similar number as well in the last 2 years. There's about 100 worldwide, so it's a first-in-man option. We did right heart catheters pre and post-operatively, and we also did echoes pre and post-operatively at regular intervals. And we used a number of various RV parameters which have been discussed today, and they're on the screen there for you. Our patients were old. They were mostly male. They all had New York Heart Association 3-4. They had secondary MR in 100% of cases, and that's partly to do with the recruitment for this device. But they were a frail population, much more frail than you would consider undergoing conventional surgery. What else did we know about their ventricles? Well, they had poor LV systolic function. They had high end diastolic and systolic volumes. Most of them had severe, if not moderate to severe MR. But just one thing that you can see at the bottom of the slide there, it's slightly cut off. They also had elevated resting pulmonary pressures. They had impaired right ventricular fractional area change. Their strain values were down. This is a snapshot of the type of vendor that I use, which is Epsilon, and I know a few other people in the room will use that as well, just to give you an idea of what our workstation is like when we're generating these pictures and images. It's very user-friendly and very good as a research tool. Now, what did we find out? Just speaking strictly to the echo at the moment, then I'll talk about the right heart catheters. You can see that, not surprisingly, the left ventricular ejection fraction out to 1 to 3 months declines. I'm not surprised. It does raise concerns worldwide, but it's just unmasking the true contractile properties of the ventricle. The thing that we did see immediately was a volume reduction, and that is very consistent with the surgical literature. at 1 to 3 months, you'll say to me, well, it's bounced right back up. We had one patient have a embolic anterior myocardial infarct, and that skewed our data. But the significant reduction at day 1 for us was quite meaningful. The global longitudinal strain tails off with the ejection fraction, but what you'll notice is the two values that hold true are the circumferential strain and the radial strain. They don't decline with other contractile properties. And we also saw a very effective reduction in MR in all of the patients. What did we see in the right ventricle? Well, we saw a meaningful improvement in right ventricular fractional area change, a meaningful reduction in pulmonary pressures. The free wall strain didn't change appreciably, and I'll talk to that in a minute, nor did the RVS prime and TAPSE. Our data for a quaternary centre with experienced reporters was what's reported worldwide, so we're comfortable with our results. And now to the right heart catheter. So at the time of the procedure, the patient's obviously intubated as it's a minor cardiothoracic surgical procedure as well. We found significantly that the RV stroke work index, which those of you who've done transplant medicine is quite a good surrogate of RV function that we use for right heart catheter, that improved immediately. So we performed the right heart catheterization on the table. They were under anaesthesia. We put the device in, and then once happy with device position and deployment, we'd perform the right heart catheter. And then with all the various other protocoling that needed to be done, about 15 minutes later before we're closing up and coming out, we repeated the right heart catheter. The most meaningful statistical improvement was at immediately post-deployment, and then it held. So what have we found? We've had 12 patients worldwide. There's been 100. In this country, there's probably been about 24, 25. It was very successful in reducing MR. And importantly, the take-home message is the volumes come down. There's an improvement intraoperatively in RV stroke work index, and that's seen on echo with right ventricular fractional area change and pulmonary pressures at 1 to 3 months. The take-home messages are RV dysfunction is common with MR. It's a direct and indirect consequence of LV volume overloading. I really encourage people to think beyond pulmonary artery systolic pressure and think of the role of the LV. We think that the RV improvement in the Tendyne is consistent with surgical patients because of the way the Tendyne butterflies the apex of the heart and causes quite vigorous septal contraction as evidenced by the circumferential and radial strain. We also think that by effectively reducing the volumes in the left ventricular chamber, that's more effective in promoting RV function. And it raises the possibility that maybe this is the long-term shift in the goalpost that we need to see. Where are we heading with our data? I've also looked at the minimally invasive mitral valve repairs Paul Jantz has done at our institution with pre-existing left ventricular dysfunction, and I hope to present that at Cardiac Society later this year. You probably won't be surprised to see that they mimic what happens in our Tendyne population. And then I've also looked at what's happening in our MitraClip cohorts with LV dysfunction. And again, hoping to present this later this year, but the volume reduction is much less impressive despite good clip results in terms of 1+ MR. So thank you for your time today.